Anna Myers and I are going to talk to you about embedding physical activity within the healthcare system, the evaluation of the Moving Healthcare Professionals programme. So the plan is that I'll give you a bit of the background and rationale for the Moving Healthcare Professionals programme. Anna Myers will then take over and talk through the phase 1 evaluation, and then I'll pick up with the phase 2 evaluation at the end.
Have I come out of share mode there, Anna?
You have, yeah.
Oh, sorry.
So just while Anna's sorting that out, there's a few people that I don't know on the call today. So I'm Anna Lowe. I'm Programme Manager at the National Centre for Sport and Exercise Medicine, and I'm an Associate Professor at Sheffield Hallam University. And I'm a physiotherapist by background, and I was, for about three or 4 years, I was involved as a physical activity clinical champion within the Moving Healthcare Professionals programme. So I've sort of gone from being part of the programme to part of the evaluation team for the programme. So Anna, do you want to just introduce yourself and then we'll carry on?
Is my mic on?
Yeah.
Yeah. So my name's Anna Myers. I'm a research fellow in the Sport and Physical Activity Research Centre, and I'm also a co-locator in the Advanced Wellbeing Research Centre. So my background is in the role of exercise and physical activity in weight management and appetite control. But since rejoining Sheffield Hallam a couple of years ago, I've worked quite a lot on projects looking at embedding physical activity within the healthcare system. One of those being this project, the Moving Healthcare Professionals programme. So I was involved in the first phase of the evaluation, which I'll talk to you a little bit more about in a moment. And then I'm also involved in phase 2 as well.
Next slide, thank you. So just to set the scene for the Moving Healthcare Professionals programme, I'll give you the background first and then we'll talk about what the programme actually involves. So this programme really arose from the need that was recognised through Everybody Active Every Day being released in, or being published in 2015. This really brought home the scale of the inactivity epidemic, the potential impact on individuals, on lives, and potentially on the sort of sustainability of the health and care system in general. Within Everybody Active Every Day, they identified 4 key domains for action: active society, active environments, moving professionals, and moving at scale. And the moving professionals was really looking at the interface that people have with professionals every day, and looking at particular groups of professionals who might be very credible, trustworthy sources of information around physical activity, and how those groups of professionals could be activated and really deployed at scale to get mass messaging about physical activity across. And just go back one, Anna, sorry. And healthcare professionals were identified as a key group within that domain, and that led to the genesis of the Moving Healthcare Professionals programme. So the programme is Sport England funded. It's a multi-year, multi-million-pound programme, and it's actually delivered through Public Health England, which is really unusual for them because they don't tend to deliver programmes. So it's quite unique in that way. It has a number of different components within it that we'll talk you through. Next slide, please. So just thinking about why healthcare professionals and why that investment is a good one. So this infographic will be familiar to some of you, I'm sure. It's from ISPA from a few years ago, and it looks at the best investments for physical activity. And you can see that number 4 there identifies that healthcare and health education, ensuring that promotion of physical activity is embedded within those systems, is seen as one of the best buys for physical activity. There's also nice clinical guidance that came out many years ago now around embedding brief advice for inactive adults into every single consultation and every single interaction within healthcare systems. So it's been broadly advocated, and we have a massive pool of healthcare professionals within England, and if those healthcare professionals were activated as messengers of those key that key advice, then the potential impact is significant, and that's really the rationale for the programme. And there's some evidence to suggest that 1 in 4 people would become more active if advised by a GP or a nurse, but physical activity isn't routinely discussed with people in up to 70 or 80% of patients or clinical interactions, and those sort of findings have been replicated across different care settings and different professional groups. There was a study a couple of years ago, just a small survey-based study from Macmillan around what proportion of people having cancer appointments actually had a conversation about physical activity, and it was only about 6% of people. And I'd say that cancer is one of the clinical areas where the evidence is strongest for physical activity right throughout the cancer pathway. So it was recognised as an area that would really benefit from a sort of at-scale intervention. Okay, next slide, please. This is also very much aligned with the Global Action Plan for Physical Activity. Again, we've got the 4 sort of key domains that are mirrored in Everybody Active Every Day, and throughout the GAPA plan, the Global Action Plan for Physical Activity, there are sort of nods to the role of the healthcare professional and the potential impact that we could have at scale if we were trained up and confident and had the knowledge and skills to convey physical activity advice in a good way to patients. Okay, next slide, thank you. So there's also quite a bit of evidence that despite that quite compelling rationale around the potential impact, it doesn't happen. So there's a survey of over 1,000 GPs from Chatterjee et al. That showed that over 80% of GPs weren't familiar with the national guidance, which is your sort of 150 minutes, etc. Less than half were confident in raising physical activity with patients, and over half had done no specific training on physical activity. And again, that's been replicated in different countries and in different professional groups. A survey that I led on a couple of years ago showed that this was over 500 physiotherapists in the UK. Physical activity status wasn't routinely discussed or measured, although about 60% of the physios knew the 150 minutes guidance. Actually, when we looked at other components, only 16% could answer very, very basic questions around the physical activity guidance, which is very disappointing to me as a physio. And also physios weren't routinely signposting their patients on to physical activity opportunities. So despite this massive opportunity that's been recognised, it really wasn't happening, which again sort of furthers the rationale. Next slide, thank you. So that led to the idea of the Moving Healthcare Professionals programme. The aim was to increase the awareness, skills and change clinical practice of healthcare professionals in the promotion of physical activity to patients at risk of or with health conditions. And there were 3 key objectives. The first was to increase awareness and skills around physical activity for the prevention and management of ill health. The second one was to change clinical practice in the promotion of physical activity. And the third was to evaluate process and impacts to identify what could be scaled up or what could be further developed. And obviously, as an evaluation team for this programme, we're very involved in the third objective there. Next slide, please. So just to talk you through this diagram, this is the Moving Healthcare Professionals model. And just a quick note that there's a reference there at the bottom to a paper that was published last year, which talks about the whole systems approach around how you meet those objectives that we've just talked through. So if anybody's interested in this area, then that paper is well worth a read. So just thinking about the journey, the educational journey that most healthcare professionals take in England, it will usually start with undergrad education, whether that's in a university setting or not. For many healthcare professionals, they will go on to do many years in postgraduate education, but that's not always the case. So for example, if you were a nurse or an occupational therapist, you might do your undergraduate education and then go on into just CPD and ad hoc continual professional development. Whereas if you are a medic, you'll do your undergrad education and then you'll spend many years in sort of formal training posts and postgrad education, and then after that you'll probably engage in ad hoc continued professional development. So there are potential intervention points across this system. So for undergraduate education, we've got the opportunity to to change the curriculum and to change the content and the way it's taught, to embed more physical activity, to embed more awareness of the impact of sedentary behaviour and the impact on potential impact on individuals and right through to health and care systems. We've got the opportunity to change professional accreditation process. We can look at professional standards. There's also targeted training opportunities, and then things like e-learning and conferences and peer-to-peer training there. So that the Moving Healthcare Professionals programme really started by looking at that journey that healthcare professionals go through and looking at the various different points that we could intervene. Next slide, please. Okay, hand over.
Yeah, thanks, Anna. So my section on this talk is going to focus on phase 1, evaluation of the Moving Healthcare Professionals programme. So just to give you a bit of background to that, so back in 2017, PHE approached the National Centre, Sheffield and East Midlands to tender for the evaluation of phase 1. And that included 4 different work streams, those being physical activity clinical advice pilot, the active hospital pilot, physical activity clinical champions pilot, and the undergraduate teaching resource. So I'll focus on the 2 pilots that Sheffield Hallam and the National Centre Sheffield evaluated. And that evaluation took place between the end of 2017 and the beginning of 2019. So just a quick introduction to the physical activity clinical advice pilot. So that's an image of the advice pad itself, and that was developed by Public Health England to be used as a tool in routine consultations to help primary healthcare professionals embed brief physical activity advice into their routine clinical practice. As you can see, well, I don't know if you can see it there, but on the image on the left-hand side, the information there is about how much physical activity people should do for health and how often they should take part in physical activity. It was designed to look like a prescription pad in the hope that that would aid compliance with the advice they received. And on the reverse of the pad, it provided tips on different ways of becoming more active and signposting to things like the Active 10 app. So the evaluation of the prescription pad pilot focused on implementation rather than looking at the impact of the prescription pad on patient physical activity behaviour. And the primary aim was to assess the acceptability of the prescription pad for healthcare professionals and also patients. And the secondary aims were to understand barriers and benefits of the prescription pad as an adjunct to routine clinical practice and explore use of the pad by different healthcare professionals. And then also understand the most effective way to implement this type of intervention in primary care. So we took a mixed method approach to explore the acceptability and feasibility of this pilot, and we looked at healthcare professionals and patient perspective using surveys, telephone interventions, focus groups, and also audits. So here's an overview of the method. So focusing on the healthcare professional first. So before they received any training on how to use the prescription pad, we asked them to complete a survey at baseline. They then received training on how to use the physical activity clinical advice pad from trained physical activity clinical champions. And we then asked them to repeat the survey at 4 weeks and 12 weeks. And this looked at things like knowledge and confidence to promote physical activity, and also their thoughts on the training they received, how often they used the prescription pad, and whether that changed over time. So we did also plan to gather information from patients using surveys and telephone interviews. So patients received physical activity advice from their healthcare professional, and then we asked practice staff to send out, practice managers to then send out survey packs to patients a couple of weeks after they received the advice. But unfortunately, despite lots of effort in getting that up and running, and NHS ethics and all the other things that you have to get in place to do to collect patient data, we didn't receive any responses, so we didn't have any patient feedback. So I don't have time to go into any great detail about the results, so I'll just briefly give you some key findings. So of the 39 healthcare professionals who provided information about the use of the prescription pad in practice, the majority said that they used the pad on a weekly basis, but very few engaged with it on a daily basis. 6 healthcare professionals use it fortnightly, and unfortunately a quarter of healthcare professionals reported never using the prescription pad. GPs, so there were a number of different types of healthcare professionals that used the pad, so GPs being the main ones, but also nurses. GPs were the ones that were most likely to use the prescription pad. And several healthcare professionals suggested that the prescription pad had been a valuable cue to kind of push them to talk about physical activity in their routine consultations, and this supports the rationale for its use and its development. However, healthcare professional engagement with the prescription pad reduced over time, and we think this was probably due to a lack of a system prompt within the electronic systems that GPs and healthcare professionals use. So in effect, it kind of sat on the GP's desk and gathered dust over time. So healthcare professionals, the reason why some healthcare professionals might not have used the pad is that they didn't see the value of the prescription pad. There were various time constraints, and also some healthcare professionals didn't think that it was appropriate to discuss physical activity with some of their patients. So some of the key challenges then as an evaluation team were that there was no intervention protocol at the outset of this, this pilot, which led to confusion amongst the pilot sites who were tasked with implementing this in their localities. And it's likely that this impacted on engagement and also use of the pad. So the confusion surrounding the implementation of the prescription pad also had a knock-on effect on the evaluation. So the changes to the delivery of and implementation of the prescription pad early on meant that we had to make changes to the evaluation, which led to having to submit ethics amendments, and relaying this information back to all the various stakeholders just meant that there was lots of confusion. So interventions in complex settings must be clearly articulated in the form of an intervention protocol prior to implementation, and co-producing this protocol with key stakeholders could reduce barriers to implementation and also increase acceptability. So recommendations that we provided for future implementation would be to involve healthcare settings or healthcare professionals in the design of the intervention right from the beginning, and then clearly articulate, as I've said, an intervention protocol that describes how the pilot should be implemented, and also append an evaluation framework to that protocol. So we suggested exploring the acceptability and feasibility of embedding the prescription pad along with prompts within the electronic systems that are used in primary healthcare settings. And whilst an electronic version of the prescription pad appeared warranted, it needed to be co-produced with patients and professionals from the outset. So if anybody's interested in any more detail on that evaluation, the full report's available via that link and the Open Science Framework. So moving on to the second pilot that we evaluated, this was the active hospital pilot. And the aim of this was to embed physical activity within secondary care this time, within a single NHS trust. So Public Health England invited expressions of interest to deliver the pilot from trusts who employed sport and exercise medicine consultants, and they received 3 applications, and we go back. Oxford University Hospital Foundation Trust were successful, and this is an overview of their model. So they had a central sport and exercise medicine consultant-led team at the centre of the model, and they then embedded physical activity within 5 different clinical pathways. So enablement, maternity, complex medical unit, cardiology, and the renal pathway. And within each of those, there was a physical activity champion that was actually on the ground within those teams, who drove the interventions in each of those pathways. They also employed a community navigator who was the link out from the hospital into the community physical activity offer. So the evaluation again aimed to explore the acceptability and feasibility of this sport and exercise medicine pilot, and it again followed a mixed method approach. Similar to the prescription pad, we gathered information from patients and healthcare professionals using surveys, face-to-face and telephone interviews, and also audits of routinely collected data. Because the interventions within each of the pathways differed, we had to take a different evaluation approach in each of the different pathways. But we did an overarching evaluation, and that's what I'll focus on today. So I'll look at the qualitative component of the evaluation, which aimed to explore the experience of healthcare professionals and patients involved in the delivery and receipt of the active hospital pilot. So we conducted, just for this specific part of the evaluation, 13 semi-structured interviews with sport and exercise medicine consultants, healthcare professionals delivering the interventions, and patients receiving treatment. So again, I can't go into any great detail, so I'll just give the key findings here. So interviews identified the importance of the active hospital pilot being consultant-led for a number of reasons. The main ones being that they have trusted relationships with key decision makers, and they also have connections across the hospital system. They have sufficient influence to affect change. They were also able to identify champions within the system, and it was clear they were able to adapt to change and ensure that the programme fits within the wider strategic framework of the hospital. So healthcare professionals emphasised the importance of the active hospital interventions fitting already easily within already existing work practices, and the need for staff training and for the interventions to be tailored for individual patient needs. And the active hospital pilot was well received by patients, but there was a lack of dedicated resource and capacity, and this was identified as a challenge by both patients and healthcare professionals. So considerations for practice then. So time needs to be factored into for the setup period to develop trusted relationships with those working on the ground, and it was also clear that undertaking a mapping exercise at the outset of the pilot to explore the physical and social environment of the hospital was important, and also to understand what's already going on with regard to physical activity within the trust. It's important to engage stakeholders early to design the intervention, and identifying key project champions on the ground will help to drive engagement, ownership and change. And there should be strategic alignment with wider priorities of the organisation, and where possible with the wider health economy. And just before I pass back over to Anna, I just want to introduce you to another project that I'm working on, which is similar to the Moving Healthcare Professionals programme in that it aims to provide education to healthcare professionals and exercise professionals around the role of physical activity in health, with the hope that they will then promote physical activity to their clients and to their patients. This is an EU funded project, so it's an Erasmus Plus project, and there are there are partners across Europe, including Greece, us in England, Cyprus, Spain, and Bulgaria. And part of that project was to develop this e-learning platform, and there's also a project website, so you can see at the top of the screen there 2 links if you're interested in having a look at that project. So one of the project tasks is dissemination, and I need to prove to the project managers that I've disseminated this project here in this meeting. So Anna's going to kindly share a link in the chat to a Google Doc. So if those of you on the call could please just follow the link and just complete input your information into that, that would be a huge help. So thank you.
So just very, very quickly, because I'm really conscious of time, just to pick up on phase 2 of the evaluation, Anna's given you an overview of 2 of the work streams that were evaluated as part of phase 1. In around about September last year, we won the contract, National Centre for Sport and Exercise Medicine in Sheffield won the contract for the phase 2 evaluation. So this is a 3-year evaluation now for phase 2, and we're working collaboratively with Ipsos Mori and National Centre East Midlands to do this evaluation. It's a really big piece of work, 3 years. We've got 6 work streams to evaluate. Each of those is a really sizable piece of work. So for example, the active hospitals work package here is there are now 4 different NHS trusts piloting different approaches, so we'll be evaluating that. Physical activity clinical champions, peer-to-peer training, for example, about 25,000 healthcare professionals have been trained through that, so really big piece of work. So we'll be evaluating each work package individually and then looking at the impact of the programme together and seeing what the sort of collective impact has been. So last slide please, Anna. So just very briefly, I've touched on our partners for the evaluation programme. It is a complex piece of work, and the system that we're trying to or that the intervention has been dropped into and that we're trying to evaluate the impact on it's a complex adaptive system, and the evaluation questions aren't so much sort of did it work, did it not work, it's which interventions or which combinations of interventions positively contributed to the change that we want to see within that system. So it is it's a challenging piece of work, but we're delighted to have the contract and to be part of it. We've also got a really strong commitment to share as we learn. So what we didn't want to do is to work with them for 3 years and then deliver a sort of interim report, end report, and then job done. We want the opportunity to feed our findings in cyclically as we go through to ensure a sort of process of continual improvement. So I'm sure Anna and I are more than happy to answer any questions now if we've got time, or over email later. And there's a few of our esteemed collaborators on screen there. Okay. So very happy to take any questions quickly if anybody has any.
Great. Can I just say thank you? There's a heck of a lot of work in there, a lot of content, so I appreciate you working your way through that. Thanks both of you. That was excellent. Any questions from the audience? I've got one, if that's all right. Well, people are thinking. We generate something like 3,500 sport and exercise science graduates every year in the UK alone. Where could they sit in terms of being paraprofessionals embedded within primary care to take some of the pressure off that primary care physician or GP having to do the advice giving in such a short period of time? So have they got a role where they could be embedded within the system?
I think there's absolutely a role for them. I think the divide between sort of healthcare and wider well-being, leisure, sport, whatever, call it whatever you like, I think there's always been this massive void between the two, which, you know, there just shouldn't be. I think we need to find ways to work much better together, much more closely together. I think the you know, the advent of link workers and social prescribing, I think will help to close that void, take the pressure off healthcare professionals, have people in place who really understand the local physical activity system and are able to direct direct people appropriately. So I think that will help. There's also another piece of work that we're doing at the moment that Kath Homer and I are leading on called Easier to be Active, and that's really looking at how the whole of the physical activity system nationally, including the whole of the healthcare sector, so it's a bit of an ambitious piece of work, how that system can work better together to make it easier for people with health conditions to be active, because we know that these parts of the system don't communicate well. It's really there's a lot of friction when people sort of cross from one part of the sector to another part of the sector. There's duplication, there's gaps. So the Easier to be Active project might be another one that Kath and I could come and talk to you about at another time.
Sounds great. And I guess the whole movement to local authorities picking up the public health agenda probably hasn't helped that disconnect either.
Yeah, I don't know. I don't know. I think there's the general feeling is that it's the right place, and it'd be really interesting to see come March what happens with PHE and where some of those sort of oversight functions around national physical activity where they get placed after that. There's certainly talk about devolving them more back locally. So it's that there isn't a perfect solution, I don't think, but I think all parts of that system need to work really hard to do a better job.
Absolutely. Any other questions, guys? Simon?
Thanks both. I have a question about the prescription pad, because I'm just really interested in the challenges, because you're doing a great job listing them all out, but what I'm really keen to sort of discuss is, we could find a technological solution. If it needs to be integrated into the main system, it could be integrated, but is there actually a big issue about education of the healthcare professionals to see the validity of the work? It seems like there's lots. I'm just wondering what the actual challenge is, or the main challenge, because by the way, I did hear all the challenges. So Anna, what do you think the main challenge is that would
I think one of the main ones was time constraints, as I mentioned. Right. Anna might want to add to this from her experience of being a physical activity clinical champion, but from the prescription pad perspective, I think the fact that it was just a piece of paper and there were no official prompts that were built into the electronic systems that they use, that was a challenge. It ended up being just another piece of paper on the GP's desks that they forgot to use. That was a big one they forgot.
So prompts would address that.
Yeah.
I'm just thinking, you couldn't get anything simpler. That's kind of where I'm approaching it from. We've always got like the simplest solution. So then there are really, it'd be really interesting to see what the challenges are. I think to actually get them to engage.
There was talk of it being embedded into the system, similar to like the monitoring BMI, for example, that just happens routinely in practice. So it would be built into the system. So they ask a question about how active are you? It might be how many days and how many minutes on those days. And based on the response to those questions, if they're not active enough, they then print off this prescription rather than it just being a piece of paper that they have to remember to use.
Yeah, I think it'd be really interesting to look across how Sheffield Health and Social Care use other screening tools, because of course it's with like laser, so in terms of alcohol addiction, drug addiction, there are other, I'm not going to say standalone because they are actually integrated, but other electronic systems that I believe get good usage. I may be wrong, but it would be quite interesting to see any lessons learned from other pathways.
Yeah, and I think there's 3 or 4 different systems that are used in primary care that I'm aware of. So anything that you develop to embed within those systems has to fit all 4. And I understand that's quite a lengthy process.
I'm just mindful on time. I think it'd be really great to hook up with Simon, and he'll no doubt build you something technological in the deal. So to help out with that. So there's a couple of questions that have come in on the chat. Nicholas, do you want to go first, please?
Yeah, hi, can you hear me?
Yes.
This is to either Anna. I had a 6 months working for a diabetes service in Leeds. I was very much the physical activity guy, but I worked amongst a team of nurses, and it was quite clear that nurses or healthcare practitioners experience taking part in physical activity themselves, their self-efficacy and their kind of attitudes towards that were key factors. And also the time constraints. It was quite clear that they had a significant workload, and they had an ever-growing caseload to deal with. So I'm aware that the moving medicine, I think it's moving medicine, one of their approaches is to invite people back for repeat appointments to then have more time to spend 15 minutes talking about that. But if they've got a growing caseload, I'm just wondering how they'd be able to to do that kind of motivational interviewing stuff. So I suppose the two key things are what impact, or did you see a relationship between the people's experience in doing physical activity, and also what impact did their caseload have, and is there room to free some of that caseload up to dedicate to physical activity?
Yeah, so on your very first point, I think there's good evidence now that healthcare professionals' own physical activity behaviour does influence how they talk to their patients about physical activity. So I think that broader promotion of physical activity to healthcare professionals for their own health has a sort of secondary impact on patients. Time comes up time and time again as a barrier, as Anna said. I don't know whether it is time or whether it's a sense of priority, because healthcare professionals will make time for clinical priorities, and often physical activity promotion isn't seen as a clinical priority, it's seen as a sort of nice to have add-on. So whether that is actually a time factor or whether it's a sort of culture change really that needs to happen there. One of the things that I think is really nice about the Moving Medicine website that you mentioned is that they've got the sort of 0 minutes consultation, the 5-minute consultation, and then the more minutes consultation. So even if you have no time left with your patient, then as they're walking to the door, if you can say, we haven't had time to talk about it today, but physical activity is going to be a really important part of your recovery, your rehab, your whatever. And next time you come in, I've made a note and we can talk about it then. I think if healthcare professionals can convey that they themselves think it's a really important part of that person's journey, then that in itself is potentially quite powerful.
Yeah, thank you.
There's probably a lot to get our teeth into with that, Nicholas. Thanks for that question. Simon Shibley, and then I think we've got one more after that.
Yeah, thanks, Jeff, and thank you, Anna. 2 quick points or questions from me. One is, to what extent are healthcare professionals themselves a good advert for the product? And 2, given that we're trying to stimulate demand for physical activity and possibly sport, how do we make it attractive rather than seem like a punishment? Like, you need to lose a few pounds, or you need to get out and do a bit more exercise, rather than something that they really value and will bring about genuine behaviour change?
Anna, I think you're probably the best one to take that with your physical activity clinical champions background.
Yeah, sure. Yeah, so I don't know that healthcare professionals are always a good advert. I think I'm interested to think about what a good advert for physical activity or a good advocate for physical activity is in that context, because it isn't necessarily somebody who is super sporty, and in fact that could have the opposite effect. I think if you've got somebody who is overweight, inactive, struggling with 3 long-term conditions, in low mood, then if your physio does a triathlon in lunch hour, then that might be quite difficult to relate to. So I think the role of the messenger and what makes a good messenger for physical activity behaviour is probably worth more consideration. I think we know that there's a massive sort of workforce wellbeing issue within the NHS, and physical activity is part of the solution there in terms of reducing burnout, reducing days lost to musculoskeletal ill health and poor mental health as well. So I think there's a much bigger job to do to support the NHS workforce to become more active. And then in terms of how we can make it more attractive, was the question, Simon, how we can make it easier for healthcare professionals to pass on the advice, or is it make it easier for less punitive for patients. Which bit was it?
Yeah, it's about the presentation, that often it comes across as being presented as a punishment. You are overweight or you are sedentary, therefore you need to do this. Whereas if you came at it from a marketing point of view, where you're selling the benefits, and we know that people are busy and we know that their time is taken. So how do you wean them off the things that they're doing already, like watching television, and valuing walking or cycling or exercise or whatever more than they do the things that they're doing currently?
Yeah, and you know, there's some good evidence about how we position those messages for people with long-term conditions, and what's sort of meaningful and relatable for people in those groups might be very different to people who don't face the same barriers. So there's evidence to suggest that if we focus on the short-term benefits rather than long-term benefits, so if you say, you know, you might die a few years later, it might not have the impact, whereas, you know, it might help you have a really good night's sleep tonight. We know sleep's a problem for you because you can't get comfy in bed and all of those kind of things. Or, you know, having a short walk in the afternoon can really help lift your mood. We know you tend to get really low and in the evenings, and sort of focusing on those very short-term impacts. The evidence suggests that is a much more powerful approach with people with long-term conditions. I completely agree, berating people for being inactive when they're already struggling with pain and fatigue and lots of other issues every day isn't the right approach.
Brilliant, thank you.
Thanks both. There's a whole new session there in terms of motives and barriers to physical activity, isn't there? So we'll pick that up next time, I think. Thanks for that. Last question from John, if that's all right.
Yeah, I'll try and be quick. Thanks for your talk. I really enjoyed that. One question from me out of interest as much as anything. So to what extent has either the intervention or the evaluation looked at the wider family health and well-being?
No, we haven't looked at that. We didn't look at that in phase one. There just wasn't scope to look beyond the healthcare professional and the patient. At the moment, we don't have any plans to look at that in phase two, I don't think, Anna, do we? No.
Yeah, just interested in kind of focusing on the person themselves, but clearly there's kind of, certainly where maybe children are involved, there's a wider family health and well-being angle that I just wondered whether there had been a focus of either of the studies or whether there are any plans to.
Yeah, that did just jog my memory. So one of the pilot sites for the active hospital pilot will look at children. So clearly carers are really important in bringing about behaviour change as well. So yeah, we are looking to explore the parents' experience of the intervention, how the healthcare professionals interact with the parent, what the impact of that is. Yeah.
Thank you.